This material is made available to you by or on behalf of the University of Melbourne under Section 113P of the Copyright Act 1968. It may be subject to copyright. For more information, visit the University Copyright website.
Welcome back, everyone. We might get the after-lunch session underway. We've got very much a pharmacology focus for the next couple of talks, and then we'll get into some clinical trials and other topics. But Andrew Burke is joining us again. He's going to talk to us about some of the pharmacokinetic challenges in treating pulmonary mycobacterial infections.
Great. Okay, thanks, everyone. So we'll talk about the pharmacokinetics now. So this is roughly the outline of what I'm going to talk about. So I guess part of the take-home messages are that PK or pharmacokinetics is complex in TB, and it probably has, well, clearly is going to have implications on clinical outcomes. I'll talk a bit about therapeutic drug monitoring. I appreciate there's probably discordance in what we can provide here in Australia compared to other low and middle income countries, which are very much endemic for TB. And for those of you going to ASA on Saturday afternoon, I'm speaking about TDM in more detail there. And I'm going to have some case studies and try and maybe use those case studies as a talk about some of the problems about PK and about some of the role of TDM as well, and talk about some of these commonly used drugs. So our focus is very much about TB, and most of this talk will be centred on tuberculosis. However, the PK implications of our mycobacterial drugs have implications for all of these other infections we treat, and I know Dan's speaking about ulcerans at the end, and we can touch upon that then as well. So some of these topics are very much generic to the overall understanding of mycobacteria. So in some ways, I think most of us like treating TB, partially because we're pretty good at curing it. And this is a patient I had about several years ago. She was a young lady from the Punjab, and she had this, terrible looking lung, and yet she had a complete recovery with 6 months of standard therapy. So we might say, well, we seem to have the PK pretty sorted. And in Australia, we have a cure rate. In the 2014 data from ANTAC, I know they're re-releasing new data soon. Our cure rate was 98.8%, and I think of those who relapsed, some of them have actually been reinfected overseas. So let's just say it's 100% for argument's sake. I think it was 17 relapses out of 1,400 people. So with standard therapy, we might think, well, we've got a really good result, and yet globally we don't see that such a high cure rate, and there might be a number of things which will impact on that, including access to medicines and poverty and so on. But the PK is, as I show you, will probably have some role in that, and maybe we haven't optimised our empirical regimens as much as we might. So this is I like this study that came out of Singapore a couple of years ago, looking at PET scans and people who have been treated and supposedly cured for tuberculosis. So this is very much a research tool. We use PET scans a lot in respiratory and lung cancer. So PET scans are looking at glucose uptake or glucose metabolism. So cancers show up as orange, but so do areas of any high metabolic activity, including tuberculosis. So these are three separate patients. These rows are three separate patients. And the first patient here has got, you can see, multilobar disease. And they've had a reduction there at 6 months. We can still see it even at the end of what's felt to be a clinical cure. These are people who all felt to have clinical and microbiological cures. There's still FDG avidity or PET avidity consistent with active disease. And when they looked at messenger RNA on bronchoscopy, they found all these patients, except for the second row, were positive for messenger RNA. They looked at about 40 patients. Messenger RNA has a half-life of only 9 minutes, so it's not reflecting dead infection. And you can see this patient here in the bottom row, they had quite marked disease. They had what's felt to be a clinical cure. You can see here, end of treatment plus 1 year later, they still had a lot of avid disease. So these are people who we feel have cured, we've cured them, we've patted ourselves on the back, and yet they still have evidence of disease activity, both on PET scanning and also on looking at their messenger RNA. So maybe what we're doing in TB is not fully sterilising the lung of TB, we're probably tipping the balance in favour of the host. But I guess it raises questions about what's the drug susceptibility like, or the drug exposure that these pathogens have been through in terms of the residual susceptibility profiles. So this is just say that some of the issues I'm talking about don't just relate to TB. This is a patient who had MAC. He's an electrician in the mines from central Queensland. and he had 18 months of intensive therapy, including about 3 to 6 months of amikacin, and still smear positive, and he had a lobectomy in December for this cavity, which came back to one of Tim's questions earlier. So, drugs that should be susceptible, but are clearly not clearing everybody, particularly with susceptible infection. So when we think about the pharmacokinetics, so we think about pharmacodynamics, that's how drugs work on the pathogen, and the pharmacokinetics is how does our body metabolize drugs? So it's absorption, distribution, elimination, and metabolism. So what does our body do to the drug, and how does that play out in clinical terms? So when we think about pharmacokinetics, a lot of our research studies are done at looking at blood or plasma and trying to get an understanding of the way the levels that we get and how much does that predict clinical outcome. But when you think about TB, it's actually, and other mycobacterial lung diseases, it's quite complex. And this is our standard sort of caseous necrosis here. So we have a sort of caseous or cheese-like necrosis. We have this sort of fibrotic rim, maybe some other inflammation, and then we have sort of normal lung around it. And if we really want to understand the PK and TB treatment, we have to really think about the PK at almost a cellular level. So we know that the persisters reside in the macrophage. Macrophage is a very low pH environment, pH about 3. Many of the bactericidal drugs, rifampicin and isoniazid, don't work well in that low pH environment. So that's why we give pyrazinamide, and that's why we've been able to shorten the duration of treatment with pyrazinamide, because it helps eradicate those persisters in the macrophage. And it's question marks then about how well do our drugs penetrate this necrotic part of the lung. So I think all of our drugs have to get through a capillary, and really these are really very avascular areas with limited penetration. This was a study that was done in South Africa where they resected for people who had treatment failure TB, and they had lung resections. Okay, so they looked at about 20 or 30 patients, I think it was, and they looked at using microdialysis, a technique of microdialysis where they put in microscopic fibres into different parts of the tissue. They could actually sample the tissue and look at both the culture growth for TB and what the susceptibility profile was, and also what the drug levels were. So these people were treated on their regimen, albeit a failing regimen, up until the day of surgery. And what they found was, as you might expect, there were very different gradients of TB drug penetration into these cavities. So clofazimine really didn't penetrate very well at all, even though we tend to think of it as a good drug in MDR TB, and we use it in non-tuberculous mycobacteria as well. Quinolones didn't penetrate very well. And when you looked at the susceptibility profile of the remaining bacteria, there was a gradient. It wasn't like they all had the same susceptibility profile. So we're seeing a spectrum of remaining susceptibility based on drug penetration. So it was in drug-resistant TB, and then this paper came out in the New England looking at fully susceptible TB. And what they're looking at then is, these are all people who should have susceptible tuberculosis based on an MIC of less than 1 for isoniazid and rifampicin of less than, so MIC of 0.01 for isoniazid and 1 for rifampicin. And if you look here on the vertical axis, this is for isoniazid. This is the percentage of strains with this degree of MIC, of relapse, I beg your pardon, those who relapsed, and this is the MIC distribution. Okay, so all in a susceptible range. What they found was, though, as you had MIC creep, even up to the sort of the clinical critical concentration, you still have high rates of relapse at the higher MICs, even at 0.031, we would consider isoniazid be fine in that setting. And then rifampicin, we see that even more, where with MIC creep, as we get up to the critical concentration, the relapse rate increases. So this is looking at the pharmacodynamics, but obviously the PK and PD go together in these settings. So people are trying to look at a number of different models to try and predict which drugs are going to penetrate the caseous necrotic area, the granuloma in the lung. So we've heard a little bit about some of the studies which I'll allude to about short course therapy with substituting quinolones for ethambutol. And this is a fairly novel thing, around a few years now, using MALDI MS imaging. So what they do is they can basically calibrate the mass spectrometer to detect a particular molecular weight. Okay, so these are rabbit studies, in fairness, and this is a rabbit lung, and this is the drug penetration, in this case rifampicin, and the green fluorescence here is TB-specific antigen. So this is a direct overlay of this lung here on the left. So you can see here that the drug doesn't penetrate well. There's that black hole there. And what's in that black hole? That black hole is actually where the TB is most concentrated. So we're not really seeing a very good match of drug distribution to where the maximum concentration of TB is. And this is the same sort of thing at steady state, and the same process here with moxifloxacin. Again, you can see moxifloxacin had poor penetration into this cavity here, which again is where the TB was residing in this rabbit model. So the same thing has been done with ethambutol. and again, it's very similar. Actually, I should say, a better penetration based on ethambutol compared to moxifloxacin. So one of the targets that one of the parameters that we use for PK PD matching is the probability of target attainment. So in mouse models of TB, it was felt that ethambutol wasn't particularly as effective as other agents, say for example quinones, and it's often been difficult to work out the susceptibility of ethambutol. And in plasma studies, they found that the levels are actually relatively low. So in terms of getting the target attainment of an area under the curve over MRC of 120, if you just looked at plasma alone, ethambutol would be a bit of a loser. But when you go on and look at how its penetration at the Cassius level, it's actually really much superior to what we see in plasma. So the punchline of this is that just looking at the plasma PK for a key drug, or an old drug that we've used for many decades of ethambutol, probably undercalls how effective it's been. And it's been proposed that maybe this is one reason why substituting moxifloxacin for ethambutol didn't result in the clinical outcomes that have been described already of the high relapse rates in short course therapy. So can therapeutic drug monitoring improve outcomes? I'm just going to intersperse some of my cases with this question. Again, obviously in Australia and other countries we have an option now for TDM based on some assays that have been developed in Brisbane. But obviously at this stage there's a discordance with what we can apply in other settings around the world where TB is obviously a much bigger issue. But it raises some questions about what we can do here at least, and then extend to other areas in certain situations. So there's lots of drugs that we use in clinical medicine, and we don't do TDM for many of them. Obviously in infectious disease, aminoglycosides and vancomycin, we're very comfortable with doing TDM in that setting. We understand the levels, it's not too hard. So when should we consider doing TDM? So I guess it's, some people talk about monitoring compliance, and that's some blunt tools which can help with that. Avoiding toxicity, obviously, if you have a narrow therapeutic range, or there's non-linear pharmacokinetics, and also if drug interactions are an issue. So if we are going to think about doing TDM and TB, which drug should we measure? How do we measure? Which patients should we test? We want to be testing everybody. And ultimately, does it change our management and in turn our outcomes? So about a year ago, we got some NATA accreditation for these assays. And these were really designed largely for research purposes, for PK, particularly in cystic fibrosis patients. There's a fair bit of money in CF research now for mycobacteria, which is funding some of the studies Rachel's mentioned. But it was also a great opportunity for our lab to also develop some mycobacterial drug assays at the same time. And so these are the assays that now are available, and all of you can order those. And I put out a flyer on Ausbug about 9 months ago, and some of you already started sending us samples, which is great. And our turnaround time now is about a week from we do a run on a Thursday, results on a Friday. So again, most of these don't have great targets that we're aiming for. So certainly a lot of them for research. Some of these like tigecycline clearly used in non-mycobacterial infections more so. But nevertheless, there's opportunities here in some situations where they may provide some value. So possible candidates for TDM could include the most important drugs, which for TB is rifampicin and isoniazid, and also those with a very narrow therapeutic window. So in medication, we already know we're getting a better understanding of how to measure that and dose adjust, but also drugs like the quinolones and linezolid. So I thought I'd just start with a case here. Now, these are cases, in Queensland we have a TB expert advisory group, and we meet once a month and we discuss difficult cases, including all our MDR cases. And so I've also provided some peripheral advice on these relating to TBM, and I'm grateful for my colleagues at other hospitals allowing me to present their patients. So this is a case of pericardial MDR TB from late last year, managed at Sunshine Coast University Hospital. So he's a 25-year-old fellow from Papua New Guinea. He's down here, I think he was working in maybe fruit picking, if I'm correct, on a work visa. And he presented to the emergency department in October, and he had 2 weeks of abdominal comfort, anorexia, fevers, cough, and dyspnea. And he's mildly distressed, and he had some signs of right ventricular strain. And his X-ray here, he's got some bilateral pleural effusion. You can see it's very large, either cardiomegaly or what turns out to be a large pericardial effusion. And he had a CT chest, which again shows significant effusions and a significant pericardial effusion. And he had hepatomegaly and ascites. So this is done on the 28th of October, this CT scan. And he went on and had a pericardial drain. So this is now 7 days after pericardial drain, before any TB treatment. So even with that pericardial window and improving his right ventricular function, you can see here those effusions have improved. So what ended up being drug-resistant tuberculosis and the pericardial fluid wasn't necessarily explaining all of what we saw in the initial X-ray and CT, which I thought was interesting. Having said that, he does now have a diagnosis of MDR TB, pericardial tuberculosis. So this is some of the data. These are some of the levels that were done for moxi and linezolid. And before we get to those, I think this is following on from Chris's talk, and I think it's a nice way of trying to look at the role of TDM in the context of the overall patient and the other data we get from the microbacterial laboratory. So this is a mutation analysis which is done, and this gyrase A encodes for low-level quinoline resistance, or the ALA does, sorry, for low-level quinoline resistance. On the basis of that, on that genotype, if you like, his moxi was put on to 600 milligrams daily, and then he's gone on to have some phenotypic testing, which is again showing low-level quinoline resistance. So that's why he was put on, instead of 400 milligrams a day of moxi, up to 600. And some levels were done and showed that levels were a little bit low, so we probably want to be around maybe 8 milligrams per litre. The levels aren't that important for the purpose of this, but it was decided to increase his moxifloxacin from 600 to 800. So he's already gone from 400 to 600 based on genotypic results, and on the basis of TDM, he's gone from 600 to 800 based on what we felt was a reasonable target. He was put on linezolid, a very similar regimen to what the Ton said, an all-oral regimen. So for linezolid, we really want, and I'll go through the linezolid targets later on in the talk, we probably want a level of less than 8 in terms of decreasing the risk of hematological toxicity as a pre-dose, as a trough level. So again, these levels are quite high, so his dose of 600 BD was dropped to 600 milligrams daily. So in this case, TDM did change our management. We increased the moxifloxacin and we decreased the linezolid. Now, he's subsequently gone back to Papua New Guinea, so we can't follow up his outcome. But that's how we're trying to get to grips with how we use these levels and how does it change our management. So if you look at linezolid dosing and therapeutic drug monitoring, it's been described in the other talks by Ton and Philip. Linezolid in the NICS study, they were giving 1,200 milligrams daily for 6 months. So it's not licensed for use or not registered for use beyond 4 weeks. So this is an off-label use of a drug with a fairly narrow therapeutic window. And the dosing is quite unclear, acknowledging some of the studies that Philip's highlighted, which are ongoing. So generally speaking, we look for an area under the curve of an MIC target of more than 100. And these are some of these have been extrapolated from non-mycobacterial studies, also on hollow fibre models that I discussed in the first talk. So a lot of the toxicity is concentration driven, particularly in the bone marrow, and also neuropathy from cumulative exposure. So the bone marrow toxicity, the anemia, seems to be seen in the first month, with the neuropathy sort of over more extended periods of time. And as I just mentioned there, which was already mentioned by Philip, in the NICS study, 70% had at least one linezolid-related treatment interruption. So it's interesting that despite the studies in South Africa, they're just trying to give 2 months in order to try and minimise that toxicity. And you see here the toxicity rates here in some of these studies: bone marrow suppression around 40%, neuropathy 20%, and optic neuropathy about 5 to 10%. Some studies saw very little optic neuropathy, so there seems to be a bit of variation there. And again, it was flagged as possible pharmacogenetic variances there or genetic differences in populations which may contribute to that. Probably most of that neuropathy and optic neuropathy, probably half, a little bit over half, is reversible with cessation of the drug, so it doesn't mean it's permanent, but nevertheless there's significant morbidity associated with that. Some studies have tried to look at therapeutic drug monitoring in this TB setting. So this was a group of patients from Colorado in America who had XDR TB and also Korea, and they found the main thing about this is the wide interpatient variability, or the wide PK variability. So these drug doses, the 600 milligrams of BD or linezolid, has been devised for soft tissue infections with MRSA and the like. And so we're using an off-label drug for dosing a very different population. And you can see here with the 300 milligrams BD, a very different trough level spread here, and likewise for 600 milligrams. So people who are fairly evenly matched can get very great differences in the levels of linezolid. In this group here, it's just interesting to note, most of them had to have about 5 previous treatment attempts for TB, so heavily treatment exposed before they got linezolid, and quite a lot of them had TB. haven't shown the slide. They also looked at the mitochondrial toxicity and they found that this was dose-related. So lactic acidosis we see a bit of with the Linezolid. That's also dose-related, again, a mitochondrial origin for that. And this is some of the toxicity that they described. And what they found is, even with a level above 2, a trough level above 2, pretty well all those people with a level above 2 got toxicity, the median time for toxicity being about 8 to 12 weeks. So I suggested a trough level of less than 4, but even below that, between 2 and 4, is significant levels of toxicity. This is a relatively small study. So what about children? So this was a study done in, there's often, as Ben would attest to, with children often left behind in all of these early clinical studies, and we're then sort of playing catch up and trying to extrapolate adult data onto children. So for children in South Africa, they looked at about 120 children, and this was a combination. Most of these were just first-pass studies, so they've only had one dose of Linezolid. About 17 of them were on long-term therapy, and they used the use of age-based sort of dosing really, and these were sort of extrapolated from, again, non-TB dosing recommendations. Of those on long-term therapy, most of them had severe anemia. And what it turned out was in this case that, again, you can see significant inter-patient variability, but we probably don't need as much dose in these South African children as we did in the other non-TB cohorts. So it was suggested that we could probably lower the dose of Linezolid and MDR TB in children. So that was an important finding. So in terms of optimising dosing, so there's been a number of different propositions about whether daily dosing or BD dosing is the optimal one. This was a good study by a good summary by Nuremberger, who's at Johns Hopkins, who did a really great sort of review of all of the PK aspects of Linezolid and TB. And they were suggesting that maybe giving a high dose every second day might be better. So what we do then is we get to maximise our area under the curve over MIC, but because a lot of its toxicity is cumulative dosing, by trying to keep the trough level lower, we can avoid some of the mitochondrial toxicity that we see with Linezolid. And these are some of the trough levels that come up in quite a number of papers. Okay, so in the first 4 weeks, maybe aiming for a trough level of less than 8, and after that, a trough level of less than 4. So obviously, the Linezolid dosing in TB is, and we use it in microbiome abscess as well. It's very much open to what we should be doing. Just a caution, in microbiome abscessus, the critical concentration of Linezolid is about 4 or so, whereas in TB it's low as about 1. So just because in MDR TB they can get away often with 300 or 600 milligrams daily, in non-tuberculous mycobacteria, we're probably still going to need a higher dose if we're going on standard PK/PD principles. So unfortunately for our abscesses where we sometimes use it, we still probably need to start out at the standard 600 milligrams BD, unless there's some other data comes through about maybe every second day giving a higher dose. So this is a 57-year-old male with TB, and he was diagnosed with HIV. This is from North Queensland, and he was Australian-born, Australian resident, and he had a CD4 count of 120, so he had an AIDS-defining illness with TB as a sentinel infection. And I was asked about whether we should be doing TDM in this fellow. He had fully susceptible TB. And the reason, he'd had quite a turbulent admission. We don't see much HIV TB co-infection now in Australia. He had a 10-week admission. He had immunoconstitution syndrome and had steroids. We put on Truvada, dolutegravir. And 3 months into treatment, he was still he'd gone from 3+ smear positive to 1+ smear positive, but still culture positive. And he wasn't thriving. He still lost quite a lot of weight. And you can see here his X-ray and his CT. He didn't really have cavitary disease. He was taking all his tablets. He was admitted the whole time. And we sort of asked, well, should we be doing TDM on this fellow? And I guess my feeling was that probably not. I didn't think it was going to add much 3 months into treatment. But nevertheless, I didn't have any objection to them sending levels. So they went on to do rifampicin levels, and his Cmax was actually at 2 hours post-dose was 11, which is not too bad. We aim for a level above 8. And they worked out an AUC target. I haven't got their calculations, but the target can be 30 if you're doing standard dose rifampicin, or higher if you're going for high dose rifampicin. So by the time they got these levels back, by the time they thought about it, I think this case is good because it sort of shows the messiness of some of our clinical decision, like should we do TDM and when do we do it? So 3 months into treatment, he's not doing as well as our usual TB patients. So they ask the question, takes a week or two to decide, do the results, a week to come back. By the time the results came back, he was actually doing fine, which is probably what I would have suggested was going to happen. But it does raise questions about when we should be doing it. So if you look about, I'll talk about rifampicin in the next slide, but I think part of if we are going to do TDM, I'm not saying we should do it, certainly we shouldn't be doing it for everyone. As I've said to you, in Australia, we have close to 100% cure rate, so we're not going to see a signal in terms of improvement. But this is someone who probably could have benefited from a more bactericidal regimen early. We know that people with AIDS have lower rifampicin levels. That's been well demonstrated, both in high-income countries and low-income countries. And there's questions about what our dose of rifampicin, which I'll talk about in the next slide. But if we are going to identify patients, if we are going to do TDM, I think we need to identify early. We're trying to avoid people having treatment failure at 3 months or slow to thrive at 3 months. We really want to look at those people who may have low levels. And that's going to be people with, say, in this case, HIV/AIDS, diabetics, people with type 2 diabetes seem to have lower absorption of TB drugs, and that's been shown in India. So India hasn't, even though they've invested heavily in TB, it hasn't come down as much as they would hope, and it's been postulated that as they become more obese with better standard of living, and type 2 diabetes has increased. Type 2 diabetes is a risk factor for TB in the first place, and it's also worsens your sort of absorption of TB drugs. So maybe diabetics might be somebody we might think about, and people at the extreme of weight and age perhaps may also benefit. This is just sort of to think about it. So if we just go on to rifampicin generally, so rifampicin is a cornerstone of our TB drugs. When it was the dose of 600 milligrams daily that was devised. That was out of the British Medical Research Council studies in Madras and Hong Kong in the 1950s, 60s, and that dose was chosen because rifampicin was frightfully expensive when they discovered it or developed it, and they felt the lowest level they could get away with. So it was at the lowest level of the dose response curve. And the median weight in those studies was about 50 kilos or 48 to 50 kilos of most of those patients. So that dose has been frozen in time for 50 years, okay? And there's a lot of question marks about whether that's the appropriate dose, and it almost certainly isn't. If you look at our therapeutic guidelines table, and we look at TB, we go to the chapter in therapeutic guidelines, we go to the table, and it gives us our lovely weight-based banding, and we just go to that table, and that serves us very well in Australia. But so wonder whether at a global level, maybe that's not necessarily always the best outcome. Obviously, it's going to be hard to dose adjust for these when you're using fixed dose combinations, but it raises questions about the empirical dosing, and also when you do have an option for TDM in some settings in complicated infection, whether we should consider it. I know Joe Donovan may be talking about TB meningitis in this session, so I won't talk about it. Suffice to say, people have looked at using high doses of rifampicin, and Philip mentioned that in his previous talk, and certainly in TB meningitis, it's been shown that in IV rifampicin, which gives you a higher area under the curve, there's a mortality benefit in an Indonesian study, although that wasn't replicated in an increased oral rifampicin dosing in Vietnam, although probably the dose probably wasn't high enough maybe to see a signal there. I should say that of all the TB drugs, rifampicin probably has the greatest inter-patient variability. So if myself and Jason are roughly the same body habitus, we could have a 10-fold variation in rifampicin, okay? Just through pharmacokinetic variability. So that variation is really quite marked, and other things such as HIV can impact on that even further. So isoniazid also shows significant variability, and a lot of that's pharmacogenetics. And this is a study that came out a few weeks ago looking at Chinese patients. So we're familiar with this idea of fast and slow acetylators, and often we understand that through, say, alcohol metabolism. Some people with a very small amount of alcohol get very nauseated and they change colour, and one reason why Asian people probably have lower rates of alcoholism is that they're slow acetylators for alcohol. It's unpleasant, and so they don't drink as much alcohol as other ethnic groups. But isoniazid is metabolised with different pathways. When we're talking about fast and slow acetylators, it's actually different. It's related to the N-acetylyl transferase genotype. And Ben spoke about evolutionary genomics, and I went down the rabbit hole of evolutionary genomics looking at this talk, and there's significant ethnic variations in this. And European and Middle Eastern people tend to be slow acetylators. Southeast Asian people are often more slow acetylators. North Asians are actually often fast acetylators for isoniazid. And it's probably an evolutionary pressure as well. So it was felt in the Neolithic period, like when TB came along, when people started cooking meat, that we're exposing ourselves to different toxins. Some of the toxins were cleared by the liver, some are produced by the liver and breaking down certain food products and environmental toxins. So being a slower acetylator may have given a survival advantage once we started to become more agriculturally based. That's postulated. That's why people in the Middle East, where civilization began, so to speak, and agriculture, that maybe they're more likely to be slower acetylators than other groups. Be that as it may, there's a significant amount of ethnic variation, which isn't predicted just by the fact of whether you're Chinese or not. So this is the blue dots here are fast acetylators, slow acetylators, and intermediate acetylators. And this is a concentration of isoniazid. And you see here there's quite a marked difference. And they looked at the modelling required if you're a fast acetylator. And they found that in the Chinese population, you probably needed 800 milligrams of isoniazid to try and get a bactericidal effect. So a very marked variation from our 300 milligrams that we use as a matter of routine. And this is really a third of the Chinese population, so it's not an outlier sort of group. This was looking at a Japanese population now, looking at the NAT genotype. And they looked at the isoniazid-induced liver injury. So generally speaking, if you're a fast acetylator, you clear the isoniazid quickly, and you're likely to have therefore lower isoniazid levels, but therefore that may protect the liver from injury. Okay. The flip side is if you're a slow acetylator, you may be more likely to have a good treatment outcome by killing the TB at the risk of an increased risk of hepatotoxicity. So what they did was this group is they looked at the genotype, and the genotype strongly correlates with plasma levels. And they did a randomised study where they looked at 5 milligrams a kilo was the standard dose, and they divided it up into higher or lower dose depending on whether you're a rapid or slow acetylator. Okay? Here again, 53% were rapid acetylators, only 9% were slow. And this is the incidence of liver injury. Now, this is a very broad definition of liver injury. They looked at 2 times the upper limit of normal by ALT-AST, which is less than what we would use, and where we tend to use 3 times with symptoms or 5 times without symptoms. And they also looked at the cholestatic enzymes as well, which we often don't put much weight on. Be that as it may, they found there was quite a big difference in the rates of hepatotoxicity depending on whether you gave empirical therapy or whether you dose adjusted depending on what you knew about their NAT2 genotype. When they therefore looked at treatment failure, there was again quite a marked difference. So this is the incidence of treatment failure. So this is this slow acetylation type, rapid acetylation type, intermediate. And those people, the slow acetylators had a much higher rate of drug-induced liver injury and treatment failure. Put that around the right way. So lower early treatment failure than rapid acetylators. So in Australia, there's nowhere which does a NAT2 genotyping unless someone correct me. Other ways people looked at trying to measure this, well, it's probably an important process, is looking at the isoniazid metabolites. So if you look at the ratio of, I think it's acetyl isoniazid, and the breakpoint is basically, at 4 hours, how much isoniazid have you metabolized in its end product? And people will use a breakpoint of 1.5 to say fast or slow acetylation. That's a bit fiddly because you need to do a couple of tests and think hard about it, and it doesn't give you the intermediate group. So I was speaking to our Director of Genomics at Chemical Pathology Queensland last week about maybe introducing this so we can have a way of doing some genotyping of patients who, maybe not for everyone, but people who have had drug-induced liver injury, for example, that might be useful in allowing you to dose adjust. Alternatively, you could go on and do isoniazid levels, would be another way of doing it. I'm going through this talk surprisingly quickly, which is good. So why not just increase, this is where it gets a little bit even more complicated and depressing. So why not just give everyone a high dose of isoniazid, a high dose of rifampicin? So what they found in mouse models was that when you had high levels of isoniazid and high levels of rifampicin, they actually did worse, okay? They actually had worse treatment outcomes, which sounds a bit confusing. And then when they looked at other studies in looking at the MIC mismatches in South Africa and some other groups also around the world, they found that you had this concentration-dependent antagonism between rifampicin and isoniazid. And they used a couple of fairly complex computer algorithms to determine this, called multivariate adaptive regression splines, basically deep-seated learning, what have you, to try and predict how important this was. But they found that then somebody had a high MIC to rifampicin and a low MIC to isoniazid, and vice versa, they actually did better, okay, than if they had low MICs to both isoniazid and rifampicin. And there's been a number of different hypotheses as to why why this might be. What they found is once you've got a much higher peak isoniazid level, then it sort of tends to overcome that antagonism. But around this sort of level, which is in the therapeutic target area, that it probably was clinically significant. So it makes it a bit difficult to make sort of standard sort of decisions about empirical. Let's just increase everybody's TB drugs and they'll be happy days. It's a lot more complicated than that. The flip side is that they felt, and this was also done in hollow fibre models, I should say. And what they did in hollow fibre models is that the half-life of some of these drugs is only a couple of hours. So they found if they gave people, or this is in the model, they postulated if you gave somebody, say, morning rifampicin and evening isoniazid, the drugs were cleared, they're not sort of never the twain meet, that they actually had better outcomes in the hollow fibre model. So by splitting the drug exposure, they were able to overcome that concentration-dependent antagonism. So it's complicated. I don't pretend to have a deep understanding of it, but it does raise concerns about blankets of increasing doses. Certainly for isoniazid, I think a strong case can be made for rifampicin. So what about what can we do in, say, low and middle income countries? So there's quite a few authors who have research interests in TDM, and they're often saying, well, we need to do TDM, and how practical is that? So in most countries in the world, they go for fixed dose combination, and so you're going to really you don't want to be messing with that too much. But some people have looked at sort of point of care tests. This is a urine screen. So they looked at patient self-kept diaries and about compliance. Admittedly, it was patient-directed compliance or determined compliance, and whether their urine changed colour. And they found that they were able to predict, to some degree, whether people were taking isoniazid or getting certain levels based on the change of this urine. But it's really like a lie detector test. I'm just not sure whether that's really a good use of a tool, whether that could sort of undermine doctor-patient or healthcare worker relationships a little bit. This is something that was done in something I also thought might be more practical for drugs like, say, amikacin we use less often, or say Linezolid, where this is just like a lateral flow assay, just like a pregnancy test, same sort of technology. And they devised this in fenovarapine in HIV, where they were going for a target level of above 25 nanomoles per litre, and if you had that therapeutic range, it would just change colour. So this was just a plasma test. I sort of wonder whether for drugs like Linezolid or quinolones or rifampicin, where you're wanting a particular target, whether a simple blood spot test, which resulted in a simple colour change as a point of care test, may be something that could have some utility in MDR TB or people who are failing treatment. So I've gone through that quite quickly, which is probably a good thing. So just to summarise, TB has complex pharmacokinetics. Obviously, smart people, are working hard to try and optimise the empirical dosing, and part of that is taking into account pharmacokinetics. In countries with access, maybe TDM in some selected settings, whether it be an NTM or TB, may help decision making. And maybe we need to think about some point of care testing options which may help people in sort of less well-resourced countries. So thanks very much. And
that's great. We've got time for a quick question if anyone has one.
You put azithromycin up on the first slide, so obviously you didn't talk much about azithromycin. There was earlier, I think, isn't it? So how would you...
Sorry, Tim?
Azithromycin.
Yes.
A lot of the drugs into
Yeah. So the question's about how well does azithromycin very well, big uptake in the macrophages, and so it doesn't really matter what the plasma level is like if you're going to get great lung penetration. And there was quite a big study in America looking at their MAC patients, and they found azithromycin levels did predict outcome. So yeah, intuitively I would have thought the same as what you're suggesting, that maybe it doesn't matter. But they did find that plasma levels for azithromycin were predictive of clinical outcome. I've got a reference I can flick to you.
I've got a question related to the case presented with co-infection TB and HIV.
Mm-hmm.
We do often see patients with that complex situation. When is the appropriate time to consider doing TDM perhaps?
Yes. So I think by the time, after 3 months, these patients are going to get better eventually, it seems, in the Australian setting. So but you're trying to get them better quickly, obviously. So I think in this setting, I just wonder whether 2 weeks, and somebody you think might be, see, we're sort of lucky because we're not going to have a lot of patients with TB, HIV co-infections. So in some parts of the world, you don't want to be doing it on everyone. But for us, I think if somebody, even after 2 weeks of therapy, the tests are fairly simple to do, they're cheap, I think you're spending a lot of money on these patients anyway. I think doing a TDM level early on is the way to go. I think otherwise, by the time, 3 months, the die already cast. We're trying to make a decision, do we need a high dose of rifampicin in this setting early on, or do we just go with the standard dosing? The other option is just to give a high dose of rifampicin anyway. And I was part of the reviewing panel for the therapeutic guidelines for TB. And we've stuck with the table, obviously, for a very good reason. There's not really a signal to say we should deviate from that in many situations. But I think in these cases, I think we need to think about that. How much is the test? So it's, without excluding postage and handling, it's probably about $100, okay? You get not exact, maybe less, maybe 80. The panels are made up, for most of those drug assays I showed you, are divided up into hydrophobic and hydrophilic drugs. So, say for example, clofazimine, ethambutol and the macrolides all in the one panel. So you sort of get all those tested in the same test. And likewise, a lot of the other TB drugs will be tested at the same time. So if you ask for, even if you had like people on 6 different drugs, for 2 tests you'll cover all of those, if that makes sense. So it's like a battery of tests within the one assay. So you don't have to, you're not getting charged for every single drug. Okay?
Great. Thanks, Andy. Okay, next I'd like to welcome up Dr. Suzanne Parker. She's an MHMRC Early Career Research Fellow, and one of her big interests is in how we can make pharmacokinetic studies more feasible. And so she's going to present some information on innovations in pharmacokinetic studies for anti-mycobacterials.
Thanks, Jason. As Jason says, I'm looking in the area of innovation to facilitate PK studies. My background is chemistry, particularly bioanalysis, where we measure drug concentrations in just about any biological substance you can find and send to us. And so I guess a lot of my work is around where I've seen changes in my field and where they can start to improve work in a clinical environment. So Andrew's just been talking to us about the PK studies, the importance being if you've got suboptimal drug concentrations, it can lead to acquired drug resistance and poor outcomes. But performing a pharmacokinetic study can be very challenging. As you can see from the blue spots, to describe a profile, you're collecting 5, 6, up to 8 samples of blood, and this can be quite a large volume of blood. These have been performed in adults, and what you'll often find traditionally is we were collecting 5 to 10 mils, and my work is around where we're being able to reduce that. And to my knowledge, nobody's collecting blood in bowls. So the challenges for anti-mycobacterial PK studies are in part the resource constraints. So anti-mycobacterial treatment is often delivered by government and NGOs. And I think what we're seeing and what we're hearing about today is that we may be moving in a direction where there is going to be a requirement for individualised management, where we might need to redefine empiric dosing for drug resistance. And this might need to occur in a local area. The challenge there is that you require highly specialised equipment for measuring drug concentrations. And as you can see, that requires a mass spectrometer for a lot of our work. And this is where my work has changed in the last few decades, and where we've been able to now change the way we can perform pharmacokinetic studies. So a couple of decades ago, we would require a mil of plasma to perform our analysis in the laboratory. And due to the changes in sensitivity and selectivity of the mass spectrometer, what we're seeing now is we've been able to reduce those volumes. And that's brought us into a world where we're starting to look at microsampling. A lot of you will have heard about dry blood spots, and this has been used since the 1960s for neonatal screening, where you're looking for a yes-no answer. But in the last decade or so, people started to look at whether or not they could use this to measure a concentration. And I'll talk you through some of the advantages and disadvantages of that. Some of the other types of microsampling, what you can see just alongside the dry blood spots is a capillary microsample. This is where we collect blood into a capillary tube that contains an anticoagulant. These are used at point of care testing in paediatric wards, so the nurses are very used to using these. And what we're looking at doing is taking that sample, centrifuging it, and then harvesting the plasma. And just below that, what you can see is where we're taking that sample, removing the red blood cells, and then applying the plasma to a dry blood spot card, or making a dry plasma spot. For the analysis of some of the drugs that some of the antimicrobials that we're looking at, we're now looking at measuring concentrations in 2.5 microlitres of sample. That's all we need for a bench analysis. And so that's really reducing that volume that's required to be taken from a patient. I've got a video here for you of another device, if I can get it started. So this is called a VAMS device, or a volumetric absorptive microsampler. And what you can see is we take a finger prick of blood, and the device collects or wicks the blood up onto the tip. It's a polymeric tip that takes 10 microlitres of blood. Now, the advantage of this is it's a known volume, and if we can get a known volume, we can derive a concentration. And I'll talk a little bit more on how that relates to dry blood spots further on. The other device I thought you might like to have a little look at, and I've got another video, is this device here. It's called a microsampling wing. And so what happens is we collect, again from a finger prick, and you'll see I'm self-sampling here, we collect 23 microlitres of blood into the device. The device is then centrifuged and the red blood cells fall to the base of the device. It then snaps apart and you're left with two segments in an H shape. These separate again and we have an analysis of 2.8 microlitres of plasma. And so we're looking at applying these types of microsamples into pharmacokinetic studies and how this can facilitate this work. Great. And so the advantages, as you've seen, is most definitely being able to reduce blood volumes. This is of benefit when we're taking a clinical study through an ethics committee. It's a big issue taking multiple samples from a neonate, from a child, to perform a pharmacokinetic study. So being able to reduce that volume, and I've spent quite some time talking to ethics committees, and they're very engaged in this reduced volume. So we can perform a pharmacokinetic study on 0.25 mils of blood. That is, less than a single sample. There's also a simplification in obtaining the sample, if you can obtain by finger prick. It's dry blood spots is extremely cheap and simple to collect. The finger prick sampling is simple, and it's also a technique that could be used for self-sampling. There's a simplification in sample processing if it can be a dried sample. You don't need to look at centrifuges. You can just dry the sample, and then there's also a reduced cost of shipping if you don't need to keep it on dry ice. And then again, there can be advantages in stability during storage. Some analytes are more stable in a dried form. And then there's also the potential for some dry blood samples to reduce the biohazard risk. And there are certain dry blood spot cards that can lyse the cells, making them safer for transport. And I've just got some papers there that, there is quite a few people looking in this area, particularly for tuberculosis treatment and therapeutic drug monitoring of TB patients. So to implement microsampling into a clinical study, there's two levels of validation that need to be performed. One is a laboratory-based validation, and the other one is a clinical validation. And I'm just going to walk you through that. And it's going to be a little bit statistics heavy. I'll show you quite a few Bland-Altman plots where we're just comparing the gold standard to the microsample. So we can, but I'll walk you through that comparison and how that relates to its acceptability. So for a laboratory-based validation, this is really following a very prescriptive guideline from the EMA and the FDA. They tell us what to look for, and I'll run through some of the papers that are out so you can see what to look for if you're interested in microsampling. The validation, we're looking for accuracy and precision, or bias and precision. Pretty much across the board, what you're looking for is an acceptance criteria of 15%. You want your data to be within 15%. But we also are looking that it's suitable across a linear range. It's not going to be impacted by the matrix. So your analytical method has to be reliable if it's in whole blood, if it's in plasma. That matrix can't impact on the result of your data, because if that matrix changes slightly, it's slightly higher hematocrit, lower hematocrit, you've still got to be able to get a reliable result. And then stability testing. And I'll show you some results that people have published on stability to give you a feel for what we look for. The recent guideline from the FDA, which was just published in 2018, is the first guideline which is giving us information on microsampling. And this has been quite long-awaited. The only microsample they looked at is dried blood spots, but for those who are working in the field and looking at different techniques, we're able to apply this to the techniques we're using. And one of the things that the FDA stated is that you can perform this laboratory validation, but you also need to provide a clinical bridging study. And this clinical bridging study is where we're comparing the microsample to conventional sampling, but in patients. And this gives us information about arteriovenous sampling to peripheral sampling, and if there's any difference between the two. The acceptance criteria of the FDA, and I'm going to keep bringing this up, so is that the difference between the samples, the difference between the concentrations in the samples, using the different techniques, has to be less than 20% of the mean in 67% of the samples. And we need to do that for a minimum of 20 samples. I'll keep reminding you of that. Okay, so this is a study that was done where they're evaluating dried blood spots for rifampicin, pyrazinamide and ethambutol. And so what they found when they compared the data from plasma to a red blood spot, what they're doing here is they're changing the matrix. So we're very used to seeing plasma, and now all of a sudden we're moving into whole blood. And they weren't able, one didn't meet the other. They weren't the same. And so they had to apply a conversion factor. And this is due to binding to red blood cells. So you're changing that dynamic of the drug in the matrix. When they did apply a conversion factor, you can see from here's our Bland-Altman. So there's two ways of describing your data using a Bland-Altman. I'll walk you through them both. This one is where we we divide our predicted versus our observed. So here what you want to see is you want to see a bias of 1. So as you can see for rifampicin, indeed, they've got a little bias. And then the next thing we're looking for is this, our limits of agreement, our upper and lower limits of agreement. And the Bland-Altman says that 97% of our data has to fall within these two lines of agreement. But that's not meeting our FDA criteria. The FDA criteria is that, again, 67% of our data needs to be within 20%. And so what we found with this data is not seen on the Bland-Altman, but the authors found that rifampicin 76% of the samples and pyrazinamide 77% of the paired samples lay within 20% of the mean. That is, that they were able to correlate them. What they did find, though, with ethambutol was only 20% of the samples lay within the 67%. So they weren't able to take this forward with ethambutol. Just briefly looking at, there's also the other way of people describing this is to use Pearson blood block regression line, and here what we're looking for is the data to go through 0 and the slope to be 1. And if the slope is not different to a line of unity, it's showing that there's no significant proportional bias, there's no bias across concentrations, and if it goes through the intercept, then there's no significant systematic bias. Interestingly in this study, and I'll come back to this in a bit, is they also recorded a facial pain score for the patients when they were collecting the samples. And these patients were paediatric patients, and on a scale of 1 to 6, where 1 was no pain and 6 is the worst pain imaginable, they scored it at 5. And this was an independent group watching the facial pain of the children. So that's an interesting result, because I think we like to think in bioanalysis that this is better for our patients. But I think this is a really important feature to think about. I'll come back on that a bit more though. This is a study, again, of dry blood spots for Linezolid patients, and they collected venous blood, whole blood, and venous plasma, whole blood, which they used, venous whole blood, which they used to create DBS, and then finger prick DBS. And just to briefly run through the validation, which is down here, as you can see, we're everything, again, trying to get under 15%. Our bias and precision is under 15%. Matrix effects, which is where we're looking at whether or not being in plasma or whole blood makes a difference, within 15%. Our stability study here, so they kept it at 37 degrees for 2 months, and it was still stable. And they also took it up to 50 degrees for 1 week, and it was still stable. So that's great for transporting a sample around, to know that you can, it's reliable. They also tested hematocrit in a range of from 20 to 50%. And I understand in a lot of TB patients you're looking at a hematocrit around 37%, 35%. So it's really important that we can get a reliable result across a range of hematocrit. They also tested the spot volume, so if how you apply the spot and whether or not that impacts on the bias of your result. And they found in this study that their bias was within 15%, even across a range from 30 to 90 microliters. And I'll show you a little bit more about how that can impact. So their ratio of DBS to plasma was 1.2, which showed that the results were higher in blood than in plasma. And this is, again, caused due to that binding into red blood cells. They also found that the results were higher in the venous dry blood spots compared to the peripheral dry blood spot. And that's a result that shows that there is a difference between capillary and venous blood. However, when they corrected the data to compensate for this, this led to, and then compared the AUCs acquired by DBS to plasma, they had a really good correlation. But it did require that correction factor. So some of the challenges for dry blood spot analysis is that if you've got a hematocrit, say of 25% compared to 55%, just as you can see here, a higher hematocrit means you're going to end up with a smaller spot on your card. And that means if you're sub-punching, so you're just taking a sample from in here, you're going to end up with a different volume compared to if you're at a hematocrit of 25%. And so this has, this means one work around this is instead of collecting, people apply a known volume of the blood, but they'll often require a pipette, and then you're at another level of participation in a study, or requiring a technical level. Others is to do an entire spot analysis, and then there's other people who've tried measuring potassium levels and correlating potassium levels with the concentration. And all of those have worked reasonably successfully. I thought I'd also show you this result, because here they do a spot at the top, a spot at the bottom, and a spot in the middle. And what you can actually see is there is a distribution of concentrations depending on where you might sample your spot. And that's another reason that people have really moved away from sub-punching a dry blood spot. This is another area of challenge for a dry blood spot, and that is, this is a study performed in 4 countries where they were collecting dry blood spots, and they were just looking at a quality assessment of the dry blood spot when it arrived in the laboratory. And what they found was, of 1,800 samples that were collected, 860 were rejected, so about 50% were rejected. And the reason of rejection, the largest reason at 34%, was due to an incorrect blood spot collection. And that's where, so a correct dry blood spot is a full drop of blood falls from the finger onto the card, and they were able to find if, or observe if the finger actually touched the spot, and that's when you see a very small spot, or if it had been collected into a capillary and then applied to the spot, and then you can actually see the ring of the capillary on the card. Also, if the finger is squeezed too hard, it forms a ring, a light ring around the outside, which is the extracellular fluid mixing them in the blood, and so the dry blood spot will have that impact. You'll be able to see that. And then 12% were rejected due to inappropriate drying. So it looks like a really good method, and I think with the right training it can be done really well. But it's definitely it's got its challenges. So because of those sorts of issues, people are looking at alternatives. And I mentioned earlier the dry plasma spots. So this is a group who've been working on quantifying linezolid in both plasma and dry plasma spots. I'm just looking at their validation. You can see here the precision and bias is within 14%. They had room temperature and 4-degree stability for 1 month, and a low recovery. And this isn't a requirement. There is no level that's acceptable, but the higher the recovery, the more likely you are to get a reliable result. But their LLOQ of 0.1 milligrams per litre was certainly sufficient for the levels they were looking at. Just popping back to the bland Altman, this is where they're looking at a difference, so we're hoping to see everything sitting along a 0, and it is just slightly lower, so they've got a bias of minus 0.7, and these are the upper and lower limits of acceptability, and they did 29 samples, and they did find that there was an acceptability between the plasma and the plasma spot. And again, what they've done is they've removed hematocrit from the issue. So they've, instead of having that impact and concern over the effect of hematocrit, that's been taken out of the picture. The next study is one I've been working on with Andrew, and this is, he'll be seeing this data for the first time as well. So this is a study we're doing, the VQuin PK sub-study. It's on 60 household contacts of patients with MDR tuberculosis in Vietnam. And we're looking at levofloxacin, and we've been using the VANS device. This is the one I showed you the first video of, and we've been using that to collect blood. We've also collected dry blood spots, but I don't have that data yet. It's coming. And our finding is that 28 of 30 of the paired samples were within 20% of the mean. And you'll remember that we were allowed 67%. If I reduce that down, instead of 20%, 15%, we're still making it. We have 77% success rate. And so really confident at an analytical level that this has been able to produce some good data. And I'll just show you another bland Altman so you see what we're comparing. We've got very little bias in the results, and yeah, and these are our upper and lower limits of agreement. So we've really got quite nice tight data on that. As part of the validation in the lab, we found that all of our bias and precision was within 11%. Stability, we have 11 months stability at room temperature, which makes for a study that's occurring in Vietnam and then sending samples to Brisbane as being very feasible. We also tested for 6 hours at 50 degrees in case our samples get stuck on the tarmac somewhere, and we were able to find that it was quite stable. And so we're working, we'll be taking that study forward and into the PK study, and we're also looking at other anti-mycobacterial drugs as well. And just my thank you.
Thank you, Susie. I was hoping you were going to say that it's really very easy and it's innovative and
Thank
no
you.
problems to be able to do this.
Actually, you're reminding me. There wasn't. So we of those samples that we did. Thank you. Sorry, Jason. Of the 30 paired samples, all of them were successfully collected. And we've also run another study using the VAMS devices. This was on renal transplant patients, and they're used to sampling. And I think it shouldn't take away from that result from the paediatric patients, because I think that's a really important result. But what we found is the patient acceptability of a venous sample and collecting of a VAMS finger prick was entirely equivalent. Probably the result that was of significance to that was the ease of collection for the nurse, and they were very supportive and interested in it because they found they were able to collect it so effectively. There we are. Sorry.
That's the question.
Yeah.
If Andrew came to you and said, I want to do a pedaculum study,
Yeah.
and would you say, that's fine, we just need to do these laboratory-based tests to work out which one of the microsamples will work best, but you'd be confident you'd be able to develop an easy microsampling technique so you could do the sampling in a community-based scenario?
Absolutely, and I would. And really, for the microsample, it's about what's the best microsample for the patient. So, a dried VAMS, a dried blood spot is really a great option. If the patient was in hospital, perhaps you'd just be better off staying with a liquid plasma spot sample. But we'd be able to do it. And I did notice, because I was just doing a little search earlier today, that no one's done it yet. So it'll be interesting.
Any other questions?
With the VAMS, can you separate the unbound drug from the drug?
No, not yet. I'm working on it. So no, the smallest volume you can get of an unbound at the moment that we've tested, and to get a reliable result, is 100 microlitres. There are different techniques, though. There's one called SPME, and so that's looking at an unbound concentration, but definitely looking at that area.
Is there more questions? Thanks, Susie.
Okay.
Okay, and the final speaker for this session is our international guest, Dr. Joseph Donovan, who comes to us all the way from Vietnam with an English accent. He works for the Oxford Clinical Research Unit there and is running a couple of large clinical trials, which he's about to tell us about. What else can I say except that it's a pleasure to have you here. Your first time in Australia, and Melbourne's turned on the weather, so hope you're enjoying your time.
Thank you. Yes, thank you very much. It's a real pleasure for me to be here today, and thank you to Andrew and to Jason for inviting me. So I'm going to talk to you about TB meningitis and reflect upon the challenges and some of my experiences from working in Vietnam. I've been working there for the last 3 years. Disclosure, this research is all funded through the Wellcome Trust. So, as a lot of presentations start off with numbers, I'm going to do the same. I think it helps to put things into context by talking about where TB falls in terms of numbers. Everyone will have seen this 10 million cases figure that comes from the WHO report, but it's also just useful to look at where these numbers come from. So we think that there are about 100,000 cases of TB meningitis every year. This is a huge estimate. Comes from some data from Germany, there's some data from Brazil, which suggests how much TB is extrapulmonary and how much extrapulmonary is TB meningitis. But we think there are about 100,000 cases per year, which might seem like not a lot of cases when you put it into context of things like malaria, dengue fever, and other conditions. However, this is a very, very nasty disease. Kills between about 30 and 50% of those it affects, and that's even if we give TB drugs. So very, very nasty indeed. Where I work, at OCRU, we're on the campus of the Hospital for Tropical Diseases in Ho Chi Minh City, and we have a 550-bed tropical medicine hospital. It's pretty big, as I'm sure you'll know, and we see about 100 cases of adult TB meningitis every year on our brain infection ward, and another couple of hundred about 15 minutes down the road at the TB hospital. So huge numbers of TB meningitis that we see. It's a bit of a checklist of doom, I suppose you could say, for TB meningitis. It's quite, when you think about the challenges we're up against, there are quite a few. It's very hard to recognise. The illness is a little bit like other meningitis. It's quite slow onset in comparison. History is a bit longer. Patients present later. We know if we diagnose them slowly, prognosis can be worse. Our diagnostic tests aren't particularly sensitive. Maybe they're getting a little bit better, and we'll come on to that. There are lots of complications. There's little evidence to guide management, really. Treatment course is lengthy, give a year of therapy, and there's also increasing drug resistance. So it looks quite bleak initially. I'm going to focus on a couple of main research interests of OCRU, and that's diagnosis and then treatment and management of adult TB meningitis. So again, just to provide a bit of a framework, I'm going to describe a case from the ward. So this is based on a case that we've seen recently. It's quite typical. It's quite a typical severe case, but it is a typical one nonetheless. So we have a 29-year-old Vietnamese male who presents with 2 weeks of fever and headache. He's fully conscious at presentation to the ward. He has some diagnostic tests specifically for TB. So we do a CSF ZN smear and also a gene expert, and they're both negative. But he has a clinical diagnosis of TB meningitis. The learning points there being that the history is a bit long. Anything over 5 or 6 days makes TB meningitis a more likely cause of the meningitis. Patients can be well at presentation. Doesn't mean that's always going to remain like that. And also the tests can be negative because they're not sensitive enough. And this can still be TB meningitis. But the CSF is very typical. There's a high white cell count, but not too high. It's lymphocytic, high protein, low glucose, and we've excluded cryptococcal meningitis, which gives us a similar picture. So a week later, unfortunately, the patient's coma score falls, and we do a CT scan of the brain, and it shows that he has hydrocephalus. So these black spaces, lateral ventricles of the brain, full of CSF. There is a blockage somewhere to the drainage of that CSF, and it continues to build as it's produced inside the brain, and those spaces are large. This causes pressure on the surrounding brain, which is bad for the patient. So we want to characterise that a little bit more. Why is that happening? So we do an MRI brain, and this shows widespread inflammation. Given we think we're giving the right TB drugs, and this patient is HIV negative, we would term this a paradoxical reaction. But this was a patient who we think were killing the bacteria, but severe paradoxical reaction. And then other things happen. We give our TB drugs, but the patient develops a drug-induced liver injury, which has been mentioned already, and I will come back to. So we have to stop rifampicin. We have to stop isoniazid. We stop pyrazinamide. But unfortunately, we're stopping our best TB drugs. We discussed whether or not to give steroids in this case, which I'll definitely be coming back to. And we decide to give steroids, but then the patient has gastrointestinal bleeding, so we have to stop them. And then just lots and lots of severe complications makes management here extremely complicated. I'm going to take a step back, just briefly go back to diagnosis. We rely on these tests. These are the initial tests, so culture is not here. These are the ones that can change the treatment we give at the start. We do ZN smear microscopy. We've looked at doing modifications to ZN smear microscopy. ZN smear microscopy, this has been around for decades. We think that if we take large volumes of cerebrospinal fluid, so up to 10 mils specifically for TB tests, we centrifuge that sample to concentrate all the TB, if it's there, inside a pellet, and then do our tests on this pellet. I think we can increase the sensitivity of this test. And then we have a look down a microscope for as long as we can, really. Half an hour, we'll do so in our lab. And we have somebody who's very experienced who looks at these daily. But even that cannot be sensitive enough, maybe 50 or 60% sensitive, a little bit higher sometimes at our institution, but throughout the world this is very variable, because there are not many TB bacteria inside CSF and TB meningitis. So we tried to modify this ZN smear. So together with groups in Indonesia and also a group in South Africa, we tested CSF for TB with a conventional ZN smear and also with a modified ZN smear, which involves some techniques to try and see intracellular bacteria. Bottom line is it didn't work. You can see the sensitivity figures, 33.9, 34.5. These tests are both of low sensitivity and of equally low sensitivity. So we can't modify that smear anymore, we don't think. But we do have GeneXpert, and again, GeneXpert has been mentioned by more than one speaker today. Expert's a very, very good test and has rightly been called a game changer already. And we have a newer version called GeneXpert Ultra. As mentioned, I think Chris might have put the slides up, there's good data for Ultra in pulmonary TB. Seems to be better at spotting the culture negatives, the HIV positives. But the data from TB meningitis is, until very recently, there was not much of it. There was a study done a couple of years ago by a Ugandan group. They had only 23 cases of TB meningitis, all had HIV. And they showed that Ultra was significantly better than Expert for detecting TB within CSF. So that's really good. But we needed some bigger studies. And last month, so there's one paper from our group, one paper from the same Ugandan group, published on the same day in the Lancet ID, and we tested just over a couple of hundred cases, so about 100 of TB each, with controls, and we found different results. So the Ugandan group again found that Ultra was significantly better than Expert for the diagnosis of TB meningitis. Our group found that whilst Ultra looked a little bit better, possibly a little bit better in the HIV uninfected group, it was not significantly better. So essentially they're the same. The reasons for these differences, we've obviously been banging our heads together and having a good think about it. There are differences between the way we operate. We sample different volumes of CSF. We process in a different way. We have different populations with different host responses and also different TB lineages. And we know that Ultra is detecting a multi-copy gene target, and there are different numbers of copies in different strains. Also, the Ugandan group was predominantly HIV infected, and ours was predominantly HIV uninfected. The important message, I suppose, is that one test does not fit all necessarily. And whilst Ultra, I think the consensus is that Ultra is better than Expert and better than Expert in TB meningitis, it's not good enough to exclude TB meningitis when the test is negative. So you can't just leave it up to Ultra and say, as good as it is, and it's our best test, you can't say it's negative, it's not TB meningitis. Unfortunately, we're not quite there yet. So the table I've put together for some work we're just submitting at the moment, this is actually a summary of all the studies of Ultra in TB meningitis. So the top two studies are the ones that were just published. 1-2 years ago is on there, and a few smaller studies. I put this up really to show you the huge range of sensitivity figures that we get. A huge problem with diagnosis in TB meningitis is that we have no real gold standard to compare to. When we have a new test, we want to say, how many cases of TB meningitis is that going to detect? What's the sensitivity? But we don't really know what to use as a reference. Sometimes we use those that are positive by mycobacterial culture. But that's not going to be all the cases. And then we have this uniform case definition, which has now been adapted for this purpose. So in 2010, the uniform case definition was a research tool designed to separate our TB meningitis cases. We had definite, probable, possible, and not TB meningitis. But now this is being used, us by ourselves included, as a reference standard. So we say, how sensitive is our test against definite and probable cases? How sensitive is it against definite, probable, plus possible cases? And this leads to just a bewildering array of sensitivity values, which cannot really help interpretation span and focus their data. And then just a very, very brief mention of LAM. So this isn't something that we've done in Vietnam, but LAM is an antigen found in the cell wall of TB. It's not hugely promising, I'm going to say, at the moment. It looks like another test that's probably not sensitive enough, but there's another way. There's still some work to go. There's a newer version of LAM that's out. Hasn't been tested in CSF yet. Hasn't been tested in paediatrics, as far as I'm aware. But another test that's maybe not sensitive enough. So diagnosis may be a little bit bleak. We do need something that's more sensitive, but the porcibacillary nature of TB meningitis makes that very difficult. I'm going to come on to management and treatment now. In TB meningitis, we have a few general concepts. We want to kill the bacteria, we want to manage the inflammation, and we want to try and treat complications. And there are others, of course, like managing the HIV if the patient's HIV co-infected. Killing the bacteria is something that a lot of groups are focusing on, and I'll come to the trial landscape of TB meningitis at the end. We want to make sure that we're on the right drugs. For that, we need to have some sensitivity data. We want to try and continue those drugs, even in the face of drug-induced liver injury, allergies, anything that's going to cause us to stop the best drugs. But what we tend to do at OCRU is we do work on managing inflammation and treating complications. We do think killing the bacteria is important. It's hugely important. However, the host inflammation might be as bad as the bacteria, it might be worse, and we want to try and switch this off when we can. So then we think about the brain. For those of you who know of the Monroe-Kelly doctrine, I'm sure lots of people here have heard about it, where we say that the skull is like a box or a fixed size container. We have about 1,400 mils of brain, about 150 mils of blood, 150 mils of CSF. And if something happens to one of those compartments, its increase is at the detriment of the other compartments, so the others must get smaller because there's nowhere for them to go. So then we think about TB meningitis. The complications that can occur can affect different compartments. It's very important for us to identify what's actually going on inside the skull. So the hydrocephalus case I put up before, this patient who deteriorated after 1 week. This is the CSF compartment of the brain that's getting bigger. That's going to be at the detriment of the brain tissue, which is stressed, and also the blood vessels. But then if you have disease within the brain, tuberculomas, neuroinflammation, it's a different compartment. It's going to press on the CSF and also the blood vessels. Sometimes you have a bit of both, as we saw in the case I presented. And then we often see low sodium in the blood, and that has an effect that we think contributes to brain edema. We don't know what to do about it. So we're working out how can we actually detect these patients and treat and manage them before it's too late. So this patient that I showed that had hydrocephalus at 7 days and deteriorated, if we'd done a CT scan of the brain every single day from the moment we met them, pretty sure we would have spotted that those ventricles getting bigger and bigger. We might have been able to step in and do something. Of course, that's completely unsafe, it's impractical as well. So we're trying to look at other ways to actually detect what we think is an increasing intracranial pressure. And we're doing something called optic nerve sheath ultrasound, where we place an ultrasound probe on the eye, around your optic nerve, so you have 2 optic nerves, around the nerve, but inside a sheath is that same cerebrospinal fluid that's inside the brain and is under pressure inside the brain. And when you get that pressure, it's transmitted around the sheath, and the sheath balloons. And we can measure that ballooning, and we say, that's a big sheath. We think that corresponds to raised intracranial pressure. This is a research tool at the moment. We need to try and validate it. A couple of diagrams here will show you the rough concept. Raised intracranial pressure, raised ICP. We think it's the standard. A couple of images. So same image, so one with calipers. So the image on your left, the big black area at the top, the vitreous body of the eye, and then you can see, don't have a pointer, but you can see below it, you see the optic nerve, the black coming down. It's wider at the top, and if you'll follow what I'm saying, it's tapering down and getting more narrow. Drawn around it on this slide. So we think that that patient's optic nerve is under, or optic nerve sheath is under raised intracranial pressure. So we think that we can detect this, maybe, but there's a lot of work still to do. It's just another example. And this is the same image you've already seen on the left compared to what we think is normal on the right. So we think the patient has raised intracranial pressure, but what are our options here? What are our therapies? We've spoken a lot about anti-tuberculous chemotherapy today, and I'm going to touch upon it again, of course, but there are other therapies when we think about TB meningitis. We don't just think about the best ways to kill the bacteria. There are a few things that have been tried, but the trial data are not fantastic. There's a very nice study in the 70s where in South Africa they gave some acetazolamide to some children. We think acetazolamide reduces CSF production. So if we can do that, then it's just going to give a little bit more space inside the skull. No one seems to have followed up on this and done any bigger trials. Then we can give hyperosmolar agents like hypertonic saline, which must try and pull free water out of the brain to again reduce what's going on in the skull. And a few drugs that reduce inflammation. But corticosteroids are our biggest focus. One of our trials has already been put up today, but I'm going to take you very briefly back to 2004 when Professor Thwaites and colleagues produced an article which described the treatment of adults with TB meningitis, and they gave them dexamethasone and it reduced mortality. It's quite a landmark paper. It was in the New England Journal, and it's kind of driven guidelines, I suppose, worldwide since. It's been supported by other data and also Cochrane review, which says we give steroids to these people. But in HIV infection, we're not entirely sure. So in Guy's trial about 15 years ago, there was only a reasonably small group, of about 90 patients with HIV. This trial wasn't powered to say specifically in HIV, do steroids reduce mortality? Overall, steroids reduce mortality, but in HIV it was trending towards benefit, but we weren't really too sure. So now, we're trying to find out. So the first of our two ongoing trials in adults with TB meningitis is the ACT-HIV trial. So this is where we recruit adults with HIV and TB meningitis, and we randomise them to dexamethasone or to a placebo. So it's a randomised, double-blind, placebo-controlled trial. Our sample size, intended sample size is 520 adults, and we've enrolled about 380. And that's since June 2017. This trial enrolls patients at 2 sites in Vietnam. The 2 sites I've already mentioned, Hospital for Tropical Diseases and our TB hospital, Pham Ngoc Thach, and also at 2 sites in Jakarta. Trial's progressing well, as I say. A few more patients since the 371 diagram here. Important just to mention why we need this in HIV patients. So we say that steroids are beneficial in TB meningitis, but why do we need to prove that in HIV steroids are also beneficial? And that's because in HIV co-infection we think the inflammation is very, very different. Maybe going back 5 years ago we might have expected to say in HIV the immune system is maybe weakened and there's less inflammation and maybe less of a role for steroids to switch off inflammation. But subsequently we've found that in HIV and TB meningitis, the inflammation is actually chaotic. It's much more. So steroids may have a greater role if steroids are improving mortality by reducing inflammation. And we don't really know why they work. So then we move on to our second trial, HIV negative patients. So you might think, well, we've already shown that steroids are beneficial in a predominantly HIV negative group of adults with TB meningitis. But it's probably not as simple as just giving steroids to all patients. A while ago now, maybe almost 10 years ago, there was some work with a gene called the LTA4H gene, so leukotriene A4 hydrolase, some zebrafish models which showed mutations in this gene, or the promoter region of this gene, really increased susceptibility to TB infection. And this was analysed more. And we now know that if there is just a single nucleotide polymorphism in the promoter region of this gene, it can leave you with 1 of 3 inflammatory responses to TB meningitis. So everybody has one of these 3 situations. You're either going to have a high inflammatory response, a medium inflammatory response, or a low inflammatory response. And these are TT, CT, and CC, respectively. So when this gene was discovered, we looked back at the samples that we had stored, already had permission to test these, and we looked at LTA4H, and we looked at who had steroids and who hadn't had steroids. It was quite clear that if you were the TT, the high inflammatory genotype, then you did very, very badly. Unless you got steroids, and then you did really, really well. But in the other two genotypes, it really wasn't clear whether steroids were helping or not. So this brings us on to the second trial, which we call the Last Act trial. Yes, a little bit of a morbid name. And this is our HIV uninfected trial. So we have, again, adults with TB meningitis. The difference is they don't have HIV this time. And when we enroll them, we test for this gene. We say, what is their LTA4H genotype? We can turn around this test in about 24 hours, and they'll get a result. If it comes back as TT, we say, well, it's just retrospective data, but that retrospective data is so strong that we must give them steroids. There is nothing else ethically to do. And we do that. But if they're the other two genotypes, we're not really sure whether we should give steroids or placebo. So we randomise them to steroids or to placebo. This trial aims to recruit 720 adults. Started in February 2018, and we're about 385 as of the last day or so. So over the 50% mark. So both these trials progressing well. We want to characterise steroid therapy a little bit more. Maybe not use it as a blunt instrument. We're looking about genotype targeted therapy here. Should also mention aspirin. So aspirin's another therapy that's finding a place in TB meningitis. Work over the last 10 years has started to provide an evidence base. We think it might reduce cerebral infarction, which is a big complication in TB meningitis. Got anti-thrombotic, anti-inflammatory properties. And a study in Vietnam looked at 120, this is a phase 2 study, looked at 120 HIV uninfected adults and showed in this study that we thought it was safe at least to proceed potentially to a larger trial. We want to make sure that the addition of aspirin isn't increasing gastrointestinal or intracerebral bleeding. So maybe aspirin has a role as well, maybe in combination with steroids. And then going back briefly to anti-TB drugs, drug-induced liver injury, which was brought up earlier, is quite important to us. We think that about 10% of our HIV-negative cases of TB meningitis get drug-induced liver injury. It's about 20% in HIV-positive cases. And this causes us to stop the drugs. So the reflex tends to be ALT goes greater than 5 times the upper limit of normal. Stop rifampicin, stop pyrazinamide, stop isoniazid. And we don't really know in TB meningitis if that is the right thing to do. So both of these two trials, they can, if a patient develops drug-induced liver injury, they can randomise again and both come in to a drug-induced liver injury study, which is where we have 3 strategies. Strategy 1, we continue the 4 first-line drugs. So we say, okay, that ALT is more than 5 times the upper limit of normal, but we're just going to hold on. We're going to continue those drugs. We're going to monitor this patient extremely closely. And these trials do have an independent data monitoring committee, trial steering committee, and we are monitoring these patients very, very closely. If that ALT goes too high, more than 10 times is our threshold, we say that's too high. We move them to a non-hepatotoxic regimen. Well, what we hypothesize we'll see, and what potentially we are seeing, is that these patients' ALTs, they're going up, but then they're just turning naturally down. And what we've been able to do is keep them on the best TB drugs. And inside the brain, there's very little window for undertreating TB. Our second strategy would just be to stop pyrazinamide. Our third strategy is our standard of care, which is to move to a non-hepatotoxic regimen of an aminoglycoside, ethambutol, levofloxacin. So the data from that will come with the 2 big trials as well. We have about 45 patients or so in this sub-study. So what's our approach to severe TB meningitis? We've got all these therapies, we've got all these ideas, and we say there's not much evidence. How do we pull this together? And when we have our patients on the ward, many of whom are ventilated, have terrible brain imaging, what do we do? We tried to, myself and a few others tried to put all this together into a diagram. Fortunately, the journals have artists, so my original sketches were made a little bit more pretty. We have to think about ways to reduce the pressure inside the brain. That's what we think is killing people. I think a lot of the complications lead to the common endpoint of raised intracranial pressure. So do we sit the patient up to aid the venous drainage and CSF drainage of the skull? What do we do with mechanical ventilation, blood pressure, drugs? How do we pull it all together? Some of this has evidence, a lot of it does not, a lot of it's, I suppose, our opinions in a way, or drawing together what is in the literature. It's very easy to write down what we don't know about managing TB meningitis. This list took me we could write this down in about a minute. There are many, many aspects of many topics in TB meningitis that don't have any evidence. Taking sodium, for example, I've already mentioned that sodium is almost always low in TB meningitis. We don't know why, we don't know if we should treat it, we don't know how we should treat it, we don't know if it even makes a difference if we treat it. We need more trial data. We think maybe the right approach is to do something a bit more simple, I suppose. So checklists in medicine are a growing force, originally from the aviation industry, and there have been a few high-impact publications. There's 3 examples here in the New England Journal over the last 10, 15 years, where very simple interventions have improved outcomes in patients. So we have to think about whether we could do something similar for TB meningitis. And this is something that was published a few months ago. So we have performers, which will tell us all the data we need to collect for a thorough assessment of TB meningitis. And then we have a priorities checklist. So if you have a patient with TB meningitis, the Glasgow Coma score falls, like the example I gave you at the start. What are the things we need to think about? If you're a pilot in the cockpit, you're pulling out a checklist that's written, this light comes on, 1, 2, 3, and you run through them. Maybe we have something similar on the wall that keeps it simple so it's used, it's got to be available, and asks very simple questions so that you can run through these things in your head. This is part of our multidisciplinary, in a way, management of TB meningitis. It needs to be validated, of course. It's just been published. So I did mention I'm going to come to the current landscape of TB meningitis clinical trials. I think this is quite reassuring that this is a busy slide. I don't really like putting busy slides up, but I wanted to get them all on there. There are 11. This is from a review of clinical trial databases a month or so ago. And the 4 that are highlighted in the short names are pharmacokinetics. And same trials again. So of all these ongoing or just about to start clinical trials, 6 of the 11, so that's the 6 highlighted, are looking at high-dose rifampicin. So we've seen already that high-dose rifampicin is starting off in pulmonary TB. When we give 10 milligrams per kilogram and we try 15 milligrams per kilogram, which in the study from our unit a few years ago, which has already been shown, now people are going with 35 milligrams per kilogram, an enormous jump, and it's almost an admission from the field that we think we're giving too little rifampicin. There is good data that more rifampicin reduces mortality, certainly when given intravenous from the Indonesian study. But now a lot of groups are going with much higher doses of rifampicin, and we'll see how that goes, really. We know that rifampicin doesn't penetrate the central nervous system particularly well. We say about 20% gets into the CSF. We don't really know about how much is getting into the brain tissue. We just measure it in the CSF. But this is quite promising. And then these studies are plus or minus linezolid, plus or minus aspirin. And a very, very interesting study being done in China, the only one without a short code, is looking at high-dose isoniazid. So we're very interested in that. This is, again, looking at fast acetylators. And if somebody's a fast acetylator, should we be giving them more isoniazid? In Vietnam, we see about 30% of our TB meningitis is monoisoniazid resistant. I mean, it's a huge amount. And our first-line regimen has isoniazid in it. So we're very, very interested in whether we should be doing NAT2 testing and whether we should be giving high-dose isoniazid. And the other trials in there are out too. And as I'm sure Ben's aware and others will be happy to see, there are some paediatric trials. And if TB meningitis is an under-researched area, then paediatric TB meningitis is certainly an under-researched area. But there are 2 started or just about to start trials in paediatric TBM. So my take-home messages are that TB meningitis has a high mortality and high morbidity. Diagnostics have low sensitivity. But, GeneXpert and GeneXpert Ultra are certainly a step forward. We do have, reassuringly, TB drug and steroid trials ongoing, so hopefully the evidence base will soon increase. But there is little evidence to guide management of our severe disease. What do we do with the sodium? What do we do with sitting the patient up in bed? How should we ventilate them? How do we reduce intracranial pressure? What do we do with our monitoring for patients most of whom won't have access to any invasive neurosurgical monitoring? Maybe simple solutions like checklists are beneficial, but these are untested at the moment. But we do have a growing research field, a recently formed TB meningitis research consortium, which is quite productive in terms of its research output. It's a chance for people around the world to get together and discuss the way forward. So this is the result of work from an enormous amount of people, hugely supportive. We have fantastic support from the Hospital for Tropical Diseases and Fan Hospital, the TB group led by Dr. Tung, and our clinical trials unit, and of course Professor Guy-Thwaites, whose support and drive in the field of TB meningitis cannot be overstated. Thank you very much.
Thanks, James. That was fantastic. Is there any questions from the audience?
Thank you so much. With most TB meningitis, I imagine it's quite a heterogeneity of area in many countries. So, how many do you get a gut feeling for outside of the capital cities, how well they're managed?
Yeah, so we don't have any good kind of prevalence data in Vietnam. We think that the way that the health system works is that the cases do tend to move to specialist centres. So we think the reasons we see so many cases at these centres are because they are just sent there, which is good, but it does require someone to think about the diagnosis initially and to do a lumbar puncture. So, I mean, of course, we see the cases where, you hear the history that a patient has been treated for bacterial meningitis for a couple of weeks, and then the patient comes to us and maybe TB meningitis is diagnosed. But other than the anecdotal cases, we don't truly know, to be honest. Be nice to, I suppose, go around and visit and find out how aware clinicians in non-specialist centres are of TB meningitis. But to be honest, we really don't know.
Chris, great talk, Joe. If you were travelling back to the UK next month with a locum, your TB meningitis patients, trials are still awaiting, what doses are you going to use next month?
Of TB drugs. Yeah, very good question. Well, I mean, if we think about what do we have? I mean, we do have a UK guideline we do have WHO guidelines, but they're not followed by everybody. I think I'd probably do some therapeutic drug monitoring, but we... Yeah, I think if we had some values from the blood, maybe we could at least have a case for saying, look, let's increase this. I think we'd have to start with what is conventional and what's in the guidelines at the moment. But with some monitoring and with speaking to the right people, I think now the field is definitely moving towards higher doses. But there is not an evidence base at the moment to say 35 milligrams per kilogram of rifampicin is safe. So I think I would judge it on the severity of the case. I know I'm very much sitting on the fence here and not giving you numbers, and that's entirely deliberate. So I will get off the fence and I'll say I will start with what the WHO recommends, but I would have a low threshold for considering a rifampicin increase. I would also find out, I mean, I've been away for a few years, find out whether we can do some NAT2 testing, find out about what therapeutic drug monitoring is available now more readily than it was when I was there a few years ago. I would be very interested in increasing some doses and monitoring closely.
I was going to ask you the same question, except I was going to ask you about aspirin.
Okay.
If you had to go back, if you were managing someone outside of a clinical trial now, just in a routine, would you be using aspirin?
No, we wouldn't yet, no. So, no, I don't think we would at the moment. We have a bit of safety data, but there's no big trial data. There are about 3 articles in total now which look at aspirin, but I don't think we have the evidence base yet to say we should give aspirin, and that aspirin does reduce cerebral infarction. We've got a good start, but I think it would be hard to justify doing that at the moment. The difference being that if you get a a catastrophic gastrointestinal bleed or cerebral bleed, then it's pretty hard to reverse that. It's going to affect what you do with other therapies like steroids, and there isn't really a strong evidence base yet to give aspirin. So no, I wouldn't.
One more question. You just...
Is there a good animal model for the pathophysiology?
There are some animal models. I mean, the studies of the way that TB meningitis comes about, based on studies by Rich and McCordock, show that you get your focus in the lung, probably travels through the blood, set up a secondary focus near the meninges, grows, ruptures into the CSF, and that's based on some pathology studies. But there are some kind of animal data as well, but these involve injecting mycobacterium into the brain, but that doesn't really include the whole thing that's going on, because we want to know how it goes into the lung, how it then goes to the brain. So I'd say not good, but from data going back quite a while, we're reasonably sure that it's almost like a two-step thing. Goes to the lung, circulates to the brain. Maybe the BCG, I might be corrected here, maybe the BCG stops that early dissemination, which is maybe why the BCG is protective against disseminated TB.
Can I just ask on a related topic, just in general? I'm picking up on a comment you made about specific populations that you tested with the TB meningitis trial that you gave results on. When I started training, there was a known insertion sequence division amongst family patients. I'm not sure whether that still holds, maybe just in that you can comment on that. But do you find with the RIF Ultra, the insertion sequence is, I believe, part of the targets that have been used? Could you comment whether that might have impacted just general TB pickup as opposed to the TB meningitis?
In relation to the expert in the Ultra paper? Well, I mean, all I can comment on is these tests, look at your RPOB, they also have these multi-copy targets. We think that these multi-copy targets are present in our lineages and also the lineages from the Ugandan group that we compared against. But other than that, I don't think I can comment on that further. No, I don't think I can, sorry.
Okay. All right, well, thanks very much, Joe. And it's afternoon tea break now. We're running a little bit behind, so maybe if you could be back here in the next 10 to 15 minutes and we'll get the final session underway, where Andrew will be chairing again. Thank you.